Hello everyone. Thank you all for joining us today and welcome to today's Distinguished Researcher webinar. Today we have three presenters with us and I want to thank all of them for taking the time to present and thank you to all of the attendees for taking the time to be here. Today we have with us Bernardo Kerman, who is a child and adolescent psychiatrist from the University of Buenos Aires. He is a doctor in psychology and holds a postdoctoral degree in psychology from the University of Flores, UFLO, Argentina. I'm so sorry if I mispronounce anything Spanish.
No, it's okay.
He lives and works in Buenos Aires. Currently, he is a full undergraduate professor at the Faculty of Psychology at UFLO, a university professor at the doctoral program in psychology at UFLO, and he is the director of the graduate program in clinical psychology at UFLO and the president of the Argentine Association of Evidence-Based Psychotherapies. He has a private practice for individual, couples, family and group therapy. He is the former president of the Argentine Association of Child and Adolescent Psychiatry and Related Professions and the former Secretary of Research and Development at UFLO. He is the author of books and numerous publications in the areas of new behavioral sciences and clinical psychology, and a researcher in clinical areas in adults, children, and adolescents. We also welcome Elena Scherb, who is a licensed clinical psychologist from UBA, a doctor in psychology from USAL, and holds a postdoctoral degree in psychology from UFLO, Buenos Aires, Argentina. She lives and works in Argentina. Currently, she is the director of the postgraduate program in clinical psychology at UFLO, the vice president of the Argentine Association of Evidence-Based Psychotherapies, recertified cognitive therapist at the Argentine Association of Cognitive Psychotherapy, and a university professor at the psychology doctorate program at UFLO. She has a private practice for individual, couples, family, and group therapy. She has authored and co-authored scientific articles and case studies with difficult patients, trained in Fernandez Alvarez's integrative model. She is a consultant on post-traumatic stress disorders and other psychological issues at a law firm. She is a SPR member since 1993, participating and presenting at numerous SPR international and regional conferences, and ex-vice president of the Latin American chapter. And lastly, we welcome Giancarlo Dimaggio, who is a psychiatrist and psychotherapist. He lives and works in Rome in the Center of Metacognitive Interpersonal Therapy. He has published over 240 papers and book chapters and 7 books in English. Metacognitive Interpersonal Therapy, or MIT, the therapy model he and his colleagues designed, is applied to adults and adolescents' personality disorders, psychosis, and recently also eating disorders in male domestic offenders. MIT has received empirical support in Italy, Australia, Spain, Denmark, and Norway. He is the editor-in-chief for the Journal of Clinical Psychology in Session, a senior associate editor for the Journal of Psychotherapy Integration, and an associate editor for Psychology and Psychotherapy, Theory, Research, and Practice. Wow, that was a mouthful, and it is amazing that you're all here to present to us and that we can learn from you. So today's webinar is titled Unaware, Unwilling, and Very Still, How to Begin Psychotherapy with Patients with Personality Disorders When Alliance is Absent. So dear presenters, please begin whenever you are ready. And Juan Cruz and I are here for any tech support and any questions in the chat.
Okay. Thank you so much, Galit, and everyone for organizing this webinar. Really, it's a very exciting situation for all of us, and I'm very glad to be here with you. Firstly, I will make a very brief introduction, and I'll try to answer our first question, which was, why is case studies relevant to psychotherapy research, no? Just to introduce a little bit our keynote speaker, Dr. Dimaggio, and my colleague, Dr. Kerman. So our starting point on evidence-based psychological interventions implies an integration of empirically validated psychological interventions, research findings, continuous monitoring of results, clinical experience, therapeutic relationship issues, personal style of the therapist, client's perspectives, case conceptualization, reinforcing context, and all these variables are intervenient variables for our understanding of psychological, evidence-based psychological interventions. Maybe we will talk a little bit from the stance of our clinical expertise today. So, um, why are case studies relevant? Well, the basics on case studies, they provide a special kind of information, like, for example, contextual understanding, hypothesis generation, interdisciplinary insights, flexibility, and in summary, while case studies lack of standardized methodologies, as you all know, they still provide critical insights and are a valuable tool for researchers seeking to understand complex issues in depth. Are case studies case reports? There are many differences between case studies and case reports, mainly in focus, purpose, analysis, and field of use. Case studies are not only relevant to psychotherapy research, but to every discipline. For example, in artificial intelligence, some case studies have made all the field a shift, no? Like, for example, the Microsoft Ace chatbot, the Compass algorithm bias, the Facebook artificial intelligence shutdown, the Uber self-driving car fatality, the Google's ethical artificial intelligence controversy, the ChatGPT's ethical misinformation issues, and the stability artificial intelligence and deepfake controversies, which is currently going on. So, what are the key takeaways from these artificial intelligence disruptions? Well, these disruptions have shaped modern artificial intelligence research, pushing for safer, fairer, and transparent systems. So they are very relevant to the whole field and to the evolution of the field in general. So, what about psychotherapy case studies in case studies in psychotherapy? Well, let me see if this works. There are several authors which made main contributions to the case study methodology, like Tracy Eels, George Silverschatz, Alan Kasdin, Fishman and Rogers, Judith Beck, between others, among others. And the benefits of these case studies can be summarized like improving in-depth understanding into complex psychological phenomena, integrating research and clinical practice, contributing to personalized treatment insights that help refine their treatment approaches for individuals with similar conditions, helping standardizing therapeutic models, also contribute to the ethical and practical feasibility, because in cases where experimental research would be unethical, providing evidence-based case studies, evidence without harm, is very helpful. Also contribute to the hypothesis generation for further empirical testing, also for historical and cultural relevance, for integrating qualitative and quantitative data, and they are also gold standard for training and supervision, serving as real-world examples for students, researchers, and clinicians, and helping to improve the theoretical concept and therapeutic techniques, illustrating in the clinical practice in real world. So, however, case studies, of course, have caveats, and between them, we can cite the lack of generalization, the subjectivity and bias, the lack of control of intervening variables, the memory and self-report issues regarding the relators are people, no, therapists or patients who are emotionally involved in the narrative. They are time-consuming and resource-intensive. because conducting a thorough case study requires extensive time and effort. I can be a testimony of this. And this is not always practical, and also there's not always a lot of funding or any funding for these kind of studies. And there are potential for ethical concerns like confidentiality or the informed consent, impact of publishing personal details must be carefully managed. So here are some case studies, takeaways from two cases that I have published. One is from a severe borderline case published in 2014 in the Pragmatic Case Studies project. And some takeaways from this publication can be resumed, like illustrating the benefits of applying integrative cognitive behavioral and systemic psychological interventions combined with medication, which was gradually reduced. That a conjoined family therapy sessions with specific goals helps. The continuous monitoring and ad hoc problem areas list helped to follow along the therapeutic process. It came out that it prevented further hospitalizations. There was a 5 years follow-up without relapse, and then a 10-year follow-up without relapse. And all this can be resumed also as cost effectiveness because this patient never again was in a situation to be hospitalized, no? Which before the treatment, she was hospitalized repeatedly. Another case, a bipolar type 2 case, which I published in the Journal of Clinical Psychology, and there I had a miraculous encounter with Dr. Dimaggio, who helped me with his rigor to publish this case. And also it showed effective integrative cognitive behavioral systemic psychological interventions that work, combining with a medication that was gradually reduced, also provided an alternative psychological treatment when patients with these characteristics reject taking medication, which was the case with this patient. Also, that conjoined family therapy sessions with specific goals work. Also, there was a continuous monitoring with standardized measures in this case, which helped follow along the process. And it had a prevention function also because, again, this patient never again was in a situation to be hospitalized, but before the treatment she was. And 10 years after that, she won't relapse, no? So there's also a cost effectiveness effect with this kind of treatments. So now I will share with you an anecdote which is not published yet with another patient, which was diagnosed with generalized anxiety disorders. I will call him the surgeon. So this patient, within his initial problems, the symptomatology met all the criteria for generalized anxiety disorder, and the therapist was considering the effective cognitive behavioral techniques, which proved to be effective with a GAD. So everything seemed to be going on, but on the session 10, the patient says, well, do you remember I told you that everything was fine with my wife? Well, there's a small detail. I don't know if it's relevant. We haven't had sex for more than 10 years now, and I have a mistress. I've always had mistresses, you know. Everybody in my professional environment has mistresses, so, well, I don't know if this is relevant. So after this session, the treatment changed and all the therapeutic strategies made a shift. The questions that guided the future of this treatment were, do you think this relates with how you feel these problems with your wife? Why are you asking, why are you feeling like this now? What are your worries? And how can you be so sure that everyone in your professional environment has mistresses? Well, if there's time, I will tell you how this treatment ended. So, as conclusions, very briefly, we need research to inform clinicians about evidence-based informed psychological interventions as much as clinicians to inform researchers about case studies to inform research. There's a case study special interest group meeting next June at SPR conference in Krakow, and I hope I can see you or some of you there. Thank you. That's all for me. Thank you. Well, now we have my colleague Bernardo. Please, it's your turn.
Speaking now, pleased to meet you. I'm very happy to see you. I'm going to do some introduction, some presentation about case study, but I'm going to start by the end of Elena's lecture about the anecdote she said. Which is the difference to work with a case study, no? In the case study, there's some specific aspects to evaluate that serve as inputs to determine the interactions, the interventions, and the techniques to be used. Let's start with the slides. Just a minute. This is the last. Okay. Just a second. As I said before, in the study case, there is a series of some aspects to evaluate. There are some inputs to evaluate, that's the input to take in order to generate some strategy. Although we work with approaches based on empirical evidence and evidence-based technical tools, each case requires a specific diagnosis and a specific treatment. Let's see the inputs in these slides. Into the schema, we are looking at we first describe the client's context. In the number one, you see the client's context. This is the outline of areas and roles that exist in the client's life and that contribute to the problem or symptom they are experiencing. For instance, the occupational context. First, if the client may or not have a job, stressors to which they may be exposed, like for instance, Elena said before, pleasure and personal satisfaction in the role, economic impact, recognition received, effectiveness and opportunity for learning and personal development, work relationships with superiors, peers, subordinates. Secondly, we have the role of study. You can see in the schema. Where the client may or may not study or may have various limitations in different aspects like confidence in one's ability to incorporate, understand, present, and apply knowledge, like motivation, possibility of putting into practice what he has been learning, concentration, comprehension, memorization, planning, facing exams with confidence, calmness, and creativity, peer integration, satisfactory and assertive interpersonal relationships with authority figures, and so on. You can see on your right, up on your right, the role of couple, the role in a romantic relationship, for instance, as a part of couple. like the example that Elena has shown, we can see that the client may have, for instance, various types of difficulties in their interaction, and that this is important. For instance, if he can share values and norms and respected or respected in the case of disagreement, protection and support provided to each other, rational communication, decision making, effective collaboration activities, mutual expression and acceptance emotion, mutually satisfying sexual relations, like Elena said, shared entertainment and recreation, stability, and on your right and down, you can see that there are aspects related to family dynamics and reinforcements for the problem or symptom. Besides, most important aspect in family relationships, for instance, effective and effective communication among members, joint decision making and problem solving, shared leadership among parents, free expression of emotions, ability to disagree, support for children's growth, satisfaction with being together, and so on. Furthermore, it is important to identify the stressors to which the family is exposed. And finally, free time, sports, hobbies, friendships, cultural, religious aspects, even treatment, therapy, and others. You can list, secondly, and specifically in relation to the problem or symptom, there is some kind of descriptive or phenomenological diagnosis. We are used to using the multimodal diagnosis. In the multimodal diagnosis, there are some dimension or modals that the problem can be involved. The biological model, affecting modal emotions, when somebody suffers and panic attack, has anxiety, fear, physical sensations like butterfly in the stomach, imagery, internally sensory representations like some catastrophic anticipations in images, cognitive thoughts, cognitive, for instance, of beliefs, judgments, behaviors, and social interactions specific to the problem. Third, the diagnosis to be considered is nosological, according to the DSM-5. If we remember what Helena has said, we would say that we can go beyond nosological diagnosis, beyond this DSM-5, and look for other inputs that are important. Furthermore, we can complement the family's role with a genogram. You can see a genogram to understand not only the current dynamics in the family, but also the history and dynamics across the 3 generations, almost 3 generations. Finally, complementary studies, including psychometric studies, various scales based on pathology or problem, neuropsychological, neurobiological, biological, and other studies that would complement the diagnosis and address the specific aspects of the consultant's problems. With all these inputs, we can make some conceptualizations and case conceptualization. It means understanding of the factors that make up the problem or disorder within their specific theoretical framework of the case, with our specific theoretical framework of the case, generating some psychological hypotheses that allow them to determine what are the factors where the therapist will intervene. These are the intervention foci to resolve the problem, symptom, or improve quality of life. The intervention focus decided within the theoretical framework that the therapist operates with evidence-based approaches, of course, and then use empirical techniques also based on evidence. Finally, you can make some monitoring, some evaluating. Just a minute. Some evaluating of the results of the intervention. The results, we can evaluate it in research, we can evaluate it in our treatment. If we don't have results, we would see if there are aspects of the conceptualization case that were wrong, or we don't have enough information about the context, if the multimodal profile was incomplete or was wrong, if we need to do more complementary studies, or check the family dynamics and generate new hypotheses and new interventions, and afterwards we can evaluate. In summary, there are some important what a sound. There are some important inputs that we have to have. Somebody can. I may listen to some noise. Thanks a lot. In summary, and finally, we have some inputs to evaluate it, to diagnose, to work with the case study, and to research. First, the context in different roles, the multimodal profile, a nosological diagnosis with this DSM-5, a complementary studies, a genogram, and with these inputs, we can make some psychological diagnosis with an hypothesis, with our case conceptualization. We can do some strategy with intervention focus when techniques with tools based on evidence. Thanks a lot. Thank you so much. Thanks, Giancarlo. Thank you very much. I have just finished.
I think it's my turn. Welcome, everyone. I've seen some friends I haven't seen in a long time. Hello, Eugenia. Hello, Guillaume. And nice to see you. And I will build in a way on some of the concepts that both Elena and Bernardo raised. And I will be in the area of case studies, but more specifically, I am working on procedures, very specific, intensive, and proceduralized steps of treatment that can be implemented both technically when delivering treatment, but I hope they can be prone to intensive analysis of session transcripts, the very time-consuming part of research that we love in SPR and that Elena just mentioned. And I will focus on something that is very common in personality disorders, that is when patients don't cooperate at all, which is common practice in psychotherapy with personality disorders. And I hope it is clear that the title of my presentation is inspired by Game of Thrones. I don't know if you remember the three sisters, the daughters of Prince Oberyn, unbound, unbent, unbroken. And this is where I start from. And it is unaware, unwilling, and very still, which is something you very commonly see in patients with personality disorder. They are not aware of their mental states. They don't describe their experience. They look like don't wanting to do anything to change. I just supervised 1 hour ago a case of a man very narcissistic. That was the diagnosis in Bernardo speaking, in Bernardo's therapy, very much narcissistic. And he wanted, the goal of therapy was that his wife, his partner, had to lose weight. Otherwise, he is not aroused sexually. That is the goal. She must lose weight. In the meanwhile, he doesn't understand why he has to be monogamous. I think is a relative of Elena patient. And that was the therapy. And if when his therapist asked, well, okay, but maybe we can't do therapy in order to have your partner lose weight, he was angry at her. Doctor, but I won't be sexually excited. And she's so fat, I can't be attracted. And he was angry at the therapist. And what do you do with this patient? Okay, you can send them, okay, go fuck off and leave my room. That's the solution. But of course, this is not what you usually do. Okay, so how do we deal with these people? And in order to deal with these people, we must overcome one implicit bias that we all psychotherapists have. I think we have it. That is, psychotherapy is about exploring mental states. Of course it is, but maybe not. Maybe it's not enough. Maybe we don't have to take it for granted, especially with personality disorder. And that's my question. And I will describe how we deal with this kind of situation. So the question is psychotherapy about exploration of mental states? Do we take this task for granted? And my answer is no. Of course, the answer is yes. We want to know more about patients' mental states, cognitions, emotions, how cognitions and emotions and bodily reaction lead to maladaptive behaviors. And we want our patients that become able to grow in their capacity to figure out what they think, feel, and that is the problem, that the problem lies inside of themselves, and they have power of their mental states, they have power over their behavior. I don't know, many of them are recognizing in this sketchy description the foundational work of Bill Stiles with assimilation of problematic experience scale. So having patients starting from, I don't know, to, okay, I'm aware this is the problem and I can work on it, okay? Of course, psychotherapy is psychotherapy, but we don't have to take for granted, we don't take for granted that this is what the patients have in mind. Things can be quite different in their mind, and we have to be aware of that. Otherwise, what happens is that patients don't change, and we as therapy just bang our heads up against the wall as a soothing strategy. So the pain of hitting our head against the wall brings relief instead of just remaining frustrated in face of our patients. Well, where is the problem? Patients with personality disorder come into our office not with the personality disorder. They are filled with symptoms, problems, complaints. Sometimes they are serious. Sometimes they are mild, but sometimes they are serious. When I mean serious, I mean aggression. I mean serious disorder eating, intense anxiety, health anxiety, problematic coping behavior, sex addiction, drugs, alcohol, avoidance, severe avoidance. There are so many. Suicidal thoughts, self-harm, risky behaviors. Shall I continue with the list? So they enter the room with a total mess, and sometimes the suffering is intense. Okay, and as therapists, it's like we have to be the healer. It's like we are already in charge of their health for the very fact they entered the therapy room. And driven by our mission, we somewhat take for granted that our patients think the way we think. That is, they know that psychotherapy is about changing their inner world somewhat. But this is not the case, and in personality disorder, very often it is not the case. And I will bring some examples, a bit different from one another, and they will pave the way to understanding how we deal with those. And my hope is that this can be transformed into process research. That is, if with difficult conditions we follow a series of technical, pragmatic steps, probably we are able to overcome the problem, or at least to prevent deterioration in the therapy relationship. That is, at least we do not harm, even if we do not bring improvement. But doing not harm with this patient is already good. And Gary is another relative of the patients already described, and he suffers from narcissistic PD with obsessive-compulsive PD trait. And it looks like having a wife and a mistress or a lover is a symptom of narcissism. No, it is not. People cheat, whatever the personality disorder. There are studies supporting that. And he says he can't leave his wife because she would suffer, as would their adolescent daughters. But he says he can't stay because he's fed up with his wife and loves the other woman so much. And he continuously worries about what to do. And he swings between two different mental states. On one hand, boredom and constriction if he stays, and happiness, arousal, but guilt if he goes with the lovers. It's very, very frequent. Of course, it can be typical of narcissism. You can see it in dependent personality disorder. It's common, okay? And apparently, he's asking his psychotherapist, a woman, a colleague of mine, to decide. But nothing she tries works. She asks for behavioral experiments. Try and stay longer with the lover. Try and abstain from texting your lover when you're with a wife. And he says yes, but he doesn't. Elena nods. I think you know the situation. And he, of course,
very much so.
I could see it. And the therapist invites him to stop repetitive thinking, but he continues worry about the consequences of adopting a certain behavior, or he ruminate, which is focused on the past, about his moral flaws. At a certain point, he says, I have decided to stay in the family because I want to be a good father. But nevertheless, he keeps texting his lover and he dates her again. So the cycle continues. The therapist tries to explore his inner states, but Gary, what is happening? And he brings associations. I remember my family, I remember my father, I remember my wife. And this seems to add, wow, it's associating past memories. Looks like a marker of progress, whatever your approach, being psychodynamic, cognitive, constructivist, whatever, but nothing changes. Lot of apparent progress, but is still, and it continues to swing between staying and leaving, leaving and staying, boredom and guilt. Nothing changes. This is completely different. The case I will bring you now is a very good example of what I'm going to illustrate. It's a totally different case. Actually, it's not Italian, it's from a training I have done in another country. And so it's for the sake of disclosure. Oh, patients, masking. And Lucy is a woman in her 50s, and she suffers from something that is always neglected. This is functional neurological disorder, previously known as somatization or conversion disorder. I have to confess that in spite of the term being quite sexist, and it was, but that was hysteria. Okay, of course, even men do suffer from the same disorder, and that's why the name have been deleted from DSM and other manuals, but actually it was a great concept which kept together manifestations that go together, that is somatization, interpersonal disorder, and alterations in the state of consciousness, dissociation. We know patients who suffer from all these elements. Giovanni Liotti, one of the founding fathers of Italian cognitivism, spent a lot of his writing about that. But what? Lucy complains because her husband doesn't help her in fixing her patio. That's the problem. She feels unsafe because she has difficulty walking because of the functional neurological disorder. Of course, any actual neurological problem has been ruled out by correct scans and like, by testing. And she say, if you clean the patio, we can build something that I can walk and reach my house without risking of falling and hurting myself. But he doesn't care. So she sees her as distant and neglectful, and he reacts with anger when she makes pressure. The therapist tries to explore her mental states. But what happened last time when your husband, instead of complying with your request, went into his room, totally ignored you, and started writing on his tablet? So what happened inside your mind? And this is the basic psychotherapeutic question. What passed through your mind? And the very question irritated Lucy. What is the point of such a stupid question? She was nervous, edgy, and the therapist was confused. What did I do wrong? But I need to understand Lucy's inner world, but she doesn't like my questions. So I'm breaking the alliance, but how? What's the problem? Are you figuring out why Lucy is reacting this way? How can we overcome, if possible, this reaction? What did the therapist actually do wrong? Because the question is correct. What happened inside your mind when your husband said no or ignored you and went in the other room playing with his tablet? What's the problem? Ricky is another patient in his 30s, and he asked for therapy because he feels he can't manage his tendency to abuse alcohol and drugs anymore. Second session, the therapist explores the reasons for stopping both, but then Ricky provided a very good reason to keep on drinking and experience different substances. Actually, Ricky is a patient of mine, and at the end of session 2, I said, well, Ricky, okay, I understand I did wrong. I spent too much time of my life without using drugs and alcohol, and I need to fix it. You made a case for, okay, drinking a lot is good, experiences different substances is good, I am wrong in the room. And I meant it in the because it was very convincing. Especially, I was convinced that I have to try with psychedelic drugs. That it made a very clear point. But then I don't see the question. What do you want from me? I was puzzled and tried to understand if alcohol and drugs serve a function. Okay, he's telling me about his abuse, so let me explore what is the role in his functioning. Because I thought if I understand this functioning, Ricky will try and strive for abstaining, for reducing use. Maybe use in order to soothe guilt, maybe to overcome emptiness and boredom, maybe in order to calm down shame, the shame he experienced before dating any girl. And it was my patient. I asked question, but Ricky gave me answer which seemed to make sense. They were about mental states. I understood a bit more of an inner world, but it was distant. I could feel it. And he was not engaged in the process. What was happening? Well, what is the common element between Gary, Lucy, and Ricky? Neither of the three was really asking for change. They were suffering. Gary's suffering was mild, obsession. Lucy was suffering a lot. Actually, we have to remember that she had neurological functional disorder and chronic pain, psychogenic chronic pain. She said, if I trip and fall, then I will experience pain and pain won't go away. So I don't have to experience pain. So hypersensitivity to pain. So these patients suffer, they ask to be helped, but things we do don't work. Okay, so before trying to fix them, we need to understand the reasons why they are not asking for a change. So this is a series of way of functioning that therapists must explore before trying to do something. Explore in psychotherapeutic jargon means a very simple thing. Ask. We only understand by asking. I'm very much against implicit understanding. Yes, of course, we sense our patients, we listen with our senses. Okay, great. We pay attention to our gut reactions. Okay, great. Countertransference, our positioning, the dance of the bodies, beautiful, enlightening. But then, if you have to act, everything needs to be explicit. Means it has to pass through language and through consistency of language with non-verbal markers. And this means, again, asking. So I hope I will give you a series of functioning styles that therapists must assess together with the patients and understand together with the patient that this functioning prevent any chance to make therapeutic progress. So this means they lead to the need to redrafting the therapeutic contract. The first problem, very frequent, is that patients suffer, they have symptoms, behavioral problems, relational problems, maladaptive behavior, but in their mind, the focus is on the external. The problem is out there in the world. The others make me suffer. They should change. My partner should lose weight. My husband should fix the patio and build that damned structure. The others are responsible for my suffering. I want to sit my pain because I can't stand it anymore. You, doctor, have to remove my pain. But when the others would change, do you figure out this in your every day at work? I think you see a lot of patients with this problem. The second element is that the consequences of symptoms and behaviors are very serious, but the reason to act things that create problem are egocentric. Alcohol, I assumed that for Ricky, alcohol was a soothing strategy. It was also, but mostly alcohol was for feeling high. Drugs helped him overcome a lot of problems, but mostly in that moment, drugs were about creativity. When I use certain substances, I enter into a rich, new, and very interesting state of mind. So, doctor, do you want me to give up with that? No, I don't. Food restriction is about having a perfect body. And putting on more weight sounds so disgusting. Let's try and convince a girl or a boy as well with anorexia, with binge eating, with bulimia nervosa to change their food habits. Would they risk the horror of gaining weight? No, they don't. Another egocentric goal, leaving my cheating husband, said Michelle, a woman in her late 30s, and putting boundaries to my mother intrusions is not an option. They give me the money I need to maintain the standard I want. I don't want to lose status. And she suffered a lot, both from her very abusive husband and very intrusive and controlling mother. But after 1 year of therapy, she was able to say, well, doctor, I realized I live in a gilded cage and I'm not sure I want to fly. 1 year of struggles. Then this is the easier to a certain extent. It's similar to point 2, but in this moment, patients enact the problems that make them suffer, but out of protective reason. If I stop worrying about the future, I will risk humiliation, rejection, abandonment, aggression. If I stop ruminating about the wrong suffered, paranoia, they will catch me off guard again, and I will risk. If I try and be autonomous, my partner will leave me, and I am afraid I can make it alone. If I decide to give up taking care of my father, who despised me for all his life, I will lose any chance to finally receive the hug I always wanted. If I become less perfectionistic, I will make mistakes and be criticized and humiliated by my boss and colleagues. I see every day in my practice and with the people I supervise. Then, again, very common with personality disorder, absence of a good relationship with the therapist. Why should I tell you my story? Because patients with personality disorders tend to predict the others will neglect, humiliate, abandon, dominate, judge, and so on. So they construct the therapy consistently with their predictions. So they ask for help, they suffer, but in their mind, in their construction, who are we? Someone who will neglect, someone who will criticize them for their flaws instead of taking care. And probably point 4 is the most researched in psychotherapy because it's all about transference research. alliance ruptures and repairs, Lester Luborsky and Chris Christoph, control mastery theory. There's a lot about this part. A bit less, I think, about the former 3 points. Point 5, absence of hope. So patients have the internalized idea that they have no power over their inner world, so exploring their own inner world is pointless at best, painful at worst. Why should I dig deeper? It only makes me suffering more, and its reasons are sharper and more vivid in this pattern, in this kind of situations. When you ask for understanding more patients in a state, you look like sadistic to the eye of the patients. But doctor, do you want me to suffer better, more intense, more clearly? What the fuck? I think, again, you have experience of these situations. Well, this was the negative. But how can we face this problem and prevent wasting time facing unavoidable alliance ruptures and frustration, and also in order to prevent complaints? Because remember, if we don't deal with the situations where symptoms are intense, suffering is high, behavioral problem and relational problems are serious, sometimes with the risk of life, anorexia nervosa, just to give you a simple example, and we don't deal with these problems, at a certain point, patients present us the bill. Sorry, doctor, but you didn't help me. Of course I didn't. You didn't give me a chance. But that was not clear since session 2 and repeated in session 3 and repeated in session 4. If we try to help people whose mental state is not in the position of asking for help and willing to do something in order to change, at a certain point, treatment fails and we are responsible. So we need to take action very soon in order to prevent therapy being pointless and us being accused by patients of not having help, which happens. So, what do we do? Just we need to adjust our attitude and take for granted, remember that we, first and foremost, this is something I will sooner or later print on the walls of my therapy room. Psychotherapy is not for the sake of understanding. Doctor, I want to understand more of my past, the reason I am this way. Fuck no. Therapy is about wanting to change something. If you want to understand something, I need you to know with you in order to change what this night, tomorrow morning. Okay, we explored the relationship with your mother and father. Beautiful. Love it. I'm moved. My heart is pounding. I'm about to tear. But why is it useful? What's the problem you suffer today, tomorrow when you wake up? So every inch of understanding must be connected to doing something tomorrow. First, never try to understand for its own sake. And any question or intervention that we do since the very first second of the first session, and in a never-ending attitude which stays as long as therapy ends, with success hopefully, we need to have in mind 3 parallel goals. And understanding mental states is one of them, by the way, but not necessarily the main one. And the goal are, and here I hope I will make the case about psychotherapy is about the realm of the explicit. as I always say, psychotherapy is conquering lands from the land of the implicit and bring them to the land of the explicit. I don't think if this includes the Panama Channel, but that's a different issue. Just kidding. No political implication. It's just fun. At least it's to me, living in Europe. Of course, we want to understand mental states together with the patients. For example, we want to understand the cognitive and affective and the ABC model, for example, of the suffering. And then we want to understand and discover personality-based regularities in their system, core constructs. The Kellian constructivists would say, maladaptive interpersonal schemas, underline symptoms and problem. But then point to assess in the moment. In the moment, I mean now. It's a range of seconds. The direction of patient's attention. 3, assessing the automatic implicit goals underlying patient's discourse and making them explicit. Let's dig into goals 2 and 3. We continually need to monitor means asking, where patients are pointing their attention to. Okay, put it in simply, we need to make clear if patients are telling the story, but while holding the others accountable for their pain. Okay. Ricky, I suffer because my wife suffers. Okay, so he ruminates, he worries, but in his mind is not focused on changing something. If we ask him, and then my colleague did, what's the image in his mind? Is not he doing something different, thinking differently. He has the image of his wife suffering, stopping suffering. So he's not focused on inner change. He's complaining, he's suffering. He said, yes, doctor, I will do what you ask. But in his mind, there is the image of his wife. The patients are told before, okay, I cannot be aroused. I'm impotent now with my wife. His language was a bit nastier. I'm being gentle. And but in his mind, he has the body of his partner, fat, thin. Okay, he was not focused on I'm telling you I'm suffering and I want to do something here. It was, doctor, I'm suffering because of that body. Okay, and if we don't ask, if we don't check where is gaze looking, inside, outside, we cannot make progress. As long as the look is the gaze is directed outside. And once we've made clear explicitly that they are suffering, they are making us witnesses of the story of the suffering, but while holding the others accountable for the pain they feel, we say, okay, I know you're suffering. I understand it. And I know you want to feel better. And you would feel better if your wife felt good, even if you leave her. Of course. I know it would be great if your partner lost weight. Of course, if the asshole of your husband fixed the patio so you don't risk tripping and falling, that would be better. 100% agree with you. Life is hard, and if life was more gentle with you, you would be fine. But then, that's what I really do in the session. But then, I can't remember, what is my role here? With this attitude. Curious. Straightforward. vertical, but still gentle and curious. Okay, but what should I do? With this continuous curiosity and questioning. I don't want to treat them. I just want to understand what am I doing in the room. And then this is similar when a goal is egocentric or pursuit to avoid pain. So we need to explore, but okay, we explore the roots of shame, the root of guilt, the traumatic moment when your father beat you when you were 7 and your mother publicly humiliated when you were 8. That's incredible. Then we make guided imagery and rescripting, EMDR, sensory motor, polyneurovagal regulation, all the fantastic tricks we have in our toolbox. But first we have to ask patients a question. But, okay, let's process the trauma. But have you ever considered that you need to consider drinking a bit less, introducing new foods, exercising a bit less, abstain from purging, not using LSD because it's dangerous, okay? And say, no, that's not an option. But then you can process whatever trauma you want. The psychotherapy won't help anyone in the room. They will continue making a mess, but with a lot of introspection, which is losing time and stealing money, either from the government or to our patients' pockets. So then we, of course, this is simple, I will skip this. We need to explore the state of the therapeutic relationship. Okay, you tell me the story, but who am I in front of your eyes? Okay, you tell me your story, but what do I think about you? How do you construct me? I am very explicit. I don't tell them how I think. I ask them, how do I think about you? What is the image I have of you? And this is the part of the, that's the great foundational, inspirational Jeremy Safran and Chris Muir work. And Jeremy is late and we still miss him. And it's about reflecting on the therapy relation, meta-communicating. So this is something you already know. But all the former processes need to be, all the former mechanisms need to be assessed with precision in seconds. Why? Very simple example, behavioral avoidance. When therapists are trying to engage patients in overcoming behavioral avoidance, the first step is to explain to the patients the pros and cons of avoidance. Because avoidance has a lot of positive sides. Actually, it reduces pain. It reduces perceived risk. It trims down anxiety in the moment. And then we have to offer some psychoeducation. Yes, avoidance reduces psychological pain in the short term, but sustains suffering and problems in the long term. And at this moment, all my colleagues I supervise, especially people coming from a CBT tradition, whatever the wave, first wave, second wave, third wave, whatever, fourth wave, it will rise sooner or later. Tsunami, the next level of cognitive behavioral therapy. Okay, so you agree and give it a try to counteract avoidance. We want to behavioral experiment. And very often patients, for example, patients with avoidant personality disorder, they nod. Okay, yes, doctor, that's a good idea. Good, very good. Good suggestion, like it. Good. Thumbs up. I will put a heart on your webpage or on your Instagram. Just kidding now, of course. And we tend to take for granted that yes means yes. But we need to pay attention to nonverbal markers. And if we do, we can note that in the very moment that this patient has said yes, he or she has already decided to avoid. Okay? Very often we don't note it. we don't realize it in the session, we bitterly discover in the next session, because they don't do the homework. They don't do the homework at all. And they say, okay, no, yes, doctor, you're right, I wanted to, but then I have problems, work, wife, children, others, parents, relatives, friends, traffic in Rome, whatever. Okay, we try again. And say, no, yes, okay, I will do. And again, it happens. Okay, but if we pay attention to their gaze in the moment, to their nonverbal markers in the moment, and we discover something that is in the very moment they say yes, they have already decided to avoid. So we pretend of having a cooperative alliance, that we have agreed on a goal and a task, but we don't. Because if we just inquire a little closer in the moment and with attention to the nonverbal markers, we discover that they are already avoiding. Okay. As I usually say, when I have to deliver homework, and we always do in our approach with our patient, whatever the symptoms, and they say, okay, no, yes, doctor, yeah, I could do it. I could. I would. If it ends with would, that's a problem. And I ask, okay, but I'm very glad. And so you will try and abstain from or expose to precisely when? I don't know. And then arousal mounts. That's a sign of engagement. But you don't get it if you just take comfort with their yes. Or if with their, oh, that's good. That would be a good idea. No, that would. If it is a good idea, we need to plan in the very moment of that very day that you will try. Then you can not do it, but then we analyze the reason for not doing it. And an answer is a good answer only if comes with some degrees of pain. So patients realize that change comes to a cost. Because, of course, change means striving for fulfilling our wishes, but paying the price of giving up our protective mechanism, our coping strategies, which are usual. So, just a moment. Okay. Actually, it's a four-step process. And this is the part, maybe I will send you another slide. Elena, I will send you a slide that you can share with participants at will, where these aspects of the task are described, because that is a part that can be translated into process analysis. I think we have to make every intervention with four steps. The first is on the therapy. That is describing explicitly patient's function in the moment. So you are driven by this goal, but you are afraid that if you do, people will treat you this way. And then in order to protect you, you try to avoid, you try to comply, you try to be submissive, or you try to calm down using drugs or alcohol or restricting or binging. Okay, so we describe the functioning and the coping procedures. Okay, so this is our task. Okay, describing the functioning include metacognitive or mentalizing failures. You try to do this, but then when you are exposed to possible criticism, you avoid. I realize I don't know very well what thoughts and emotions you experience in the moment. I know you avoid. I realize there is something missing in the puzzle. Okay. So a good formulation includes question mark. Okay. I understand what you do. I understand the context. Coming back to Bernardo's description, I don't understand the process. Okay. So this is what we have to do. And we must be careful. We must be precise. The second part is asking for feedback, because the formulation that's in our mind is pointless. The formulation is interested when it's shared. As I always say to my supervisee, never tell me we did. If you use the term we, the supervisor send you electrical shocks through the computer. I want to understand your point of view and the patient's point of view in his or her own words, not we. The we is in the air, we is everywhere. I want to understand your perspective and his or her perspective. Okay? So ask for feedback and explore what patients have in mind from their perspective. Point 3, that's the most important probably, is psychoeducation. Psychoeducation means functioning this way will lead to these consequences. The old way will protect you from, but it will give you trouble, and it will make impossible to reach some goals. Okay? The new way is there, that direction, maybe good, give you more chances for autonomy, fulfillment, self-esteem, exploration, whatever, but it comes to many costs, because it means exposing oneself to loneliness, shame, guilt, distress, fear, whatever. Okay? That's the part where all my colleagues, and when I mean all, I mean 100%, fail. Psychoeducation needs to be completely separated from the invitation to change. It's neutral. It's just a story tale. It's just, a novel. It's just the story we tell our children before going to bed. No more than that. It's a story, and we tell a story. This is the faith going through that path. This is the faith going through this new path. I'm good with both. Of course, on the new path, there is a chance to recover, to feel better. But this is all we do. No more than that, because at that very moment, we need to stay still, put a series of dots, and wait. All my colleagues at that moment push. So, shall we? No. Shall we? Nothing. It's not shall we. This is path A, this is path B. This is tricky, this is a bit less tricky, but difficult. Do you want me to sustain you going in some direction? But this is very difficult, because we need to accept that the answer is A. No, I don't want to do something. Okay? So we need to resist our urge to push them, patients, toward change. If we don't, we discover, if we don't push, we have a chance to discover that we never had an agreement. Maybe we had the bond component of alliance somewhat good, but we never had an agreement on goals, and most importantly, the most neglected element of the therapeutic alliance, we never had an agreement on task. Okay, so if we push, this lack of agreement will never pop up. So we'll keep insisting and banging our head up against the wall. So I will send you a slide which summarizes the steps, and I think I'm done, and I prefer to leave these last 10 minutes for conversation. Thank you.
Amazing. Thank you all so much for your amazing presentations. And we will open everything up for discussion. So if anyone wants to ask a question, you can use the function to raise your hand or either write it in the chat.
Or just talk.
Or just talk.
Well, everyone, first of all, thank you all for your presentations as well. Giancarlo, I find what you're saying very interesting. I found that there's sort of a conversation stopper amongst therapists that it's the phrase, therapy is not for everyone, or psychotherapy is not for everyone. And this sort of goes against it, talking about those hard patients that one would say, oh, psychotherapy is not for this person. And I think this goes with what you were saying about, we were speaking about narcissistic patients, but I think there's also narcissistic therapists, and the possibility to move away from that narcissistic position is what's going to make it possible to work with these patients. And I think that this might be the first time I'm actually hearing it said so clearly. So it's really refreshing. So I think my question is, do you think that therapy is not for everyone, or that we should start moving away from that phrase?
We totally need to move away from that stance. And actually, all my career has been about dealing with difficult clients and in particular personality disorders. But, narcissistic personality disorder is the most blatant example, but paranoid disorder is even more difficult. Obsessive compulsive PD is very difficult. Dependent PD, the woman that wanted to stay in the gilded cage had a dependent PD, and that's the beginning of our work. And all the process I described, none of them is a reason to say this person is not good for psychotherapy. They are for, I need to understand how to adapt psychotherapy in order to treat these clients without becoming mad myself. That's the process. That's why it's a continuous attempt at promoting cooperation and patients' agency instead of pushing them toward change. I don't know if I answered, Juan Cruz.
Perfectly. Thank you. Thank you very much.
Thank you very much to you.
Yes, maybe I can say something.
Yes, Guillermo.
Okay.
Ciao,
Okay.
amigo.
Thank you to all three presentations. Really good stuff. And with respect to the clinical cases, in the last ones that are now more fresh in my memory, those of Giancarlo, I was looking at those cases through the glasses of our constructivist dilemma focused approach, and I could easily see in all the cases like two parts. One part wanting to see some changes and wanting to move, wanting maybe to stop the relationship with the husband or to leave the mistress or something like that, and the other part wanting to keep that. So in our way of working, we try to help the person or to suggest the person a conceptualization of having two parts. And at some moments, one of the part is more predominant than in others. But when the not the tension between the two parts is giving them a very poor life, a very poor quality of life. So we try to promote a dialogue, maybe using the two-chair dialogue technique created by the Gestalt therapies, or using other techniques to help them to keep in the same state of mind the two positions and try to harmonize them so that they have less tension inside them and they can see the tension outside in the therapy room. And the therapist being neutral in this type of harmonization of the two parts. And some of the moments of your discourse, Giancarlo, I could see some similarities with that, and maybe not, but I just wanted to share my thoughts. It's not a question; it's just what your presentations evoked in my mind, and I just wanted to share them.
Well, Gideon, I agree with 99% of what you said, and it is similar to your dilemma focus model. Yes, it is, absolutely. And the problem is that sometimes patients do agree with experiential work, chair work, imagery work, sensory model work, but then they don't change. Because in a way, they engage themselves in the experiential task in the session, but in their mind, their focus didn't change. In a way, they were still thinking, okay, I do this, but then change, it's on the outside, it's not on me. So they do something, but then they go home and keep doing the same. Okay. So that's why I think we continuously need to agree explicitly that therapy is about doing something in their everyday life. So at that point, engagement in some homework is mandatory. Of course, we not give order, but we need to make them aware that change comes after exposure to pain in a way. And this is sometimes not achieved when the focus is on intra-session change only. I don't know if I answered, Guillermo.
Well, we could have a long discussion about that, but I think Bernardo wants also to talk and other people.
Of course.
Sorry, we will have it another day.
That's okay. Two things. First of all, you told us he changes the focus from the external problem to the internal problem. That's one of the strategies. The first asking, the first question. The second question, there's a kind of Rogerian strategy reflecting what the patient is doing or is thinking, is feeling. What's your opinion?
Well, Bernardo, as regard the first thing, it's not that changing the focus is a strategy. My position is in a way more humble, is making the patients realize they are focused on the outside. And then ask, are you okay with keeping your eyes looking there? Or shall we agree that in order to do something, it's better you focus here? Otherwise, is we pushing to change the focus? No, it's making them aware that they are focusing there, and as long as they do, nothing will happen. Okay, so it's more promote awareness and then engage them.
Just awareness.
And well, as regard Rogers, I would say no, because that's my personal opinion, which means I'm right. And just kidding, sorry. And,
No.
just kidding. And therapists only based on the so-called Rogerian qualities are not.
It's not therapy.
Exactly.
I agree.
It's just sitting there, and it's, I understand your experience. I empathize with your coping mechanism. In
And
your
so on.
situation, I would use drugs myself. Absolutely. You have 100% of my spirit and body. But if you keep using mushrooms, I'm not sure I can help you. What shall we do? Hello, Guillem.
Bye, Guillem.
I don't know
Thank you.
I don't know if
Bye.
you answer, Bernardo. Hello, Eugenia.
Bye, Eugenia.
Well, Virginia.
Well, maybe we should like finish if you agree, Galit. Just one small commentary, no? I don't know if you are hesitating about what happened with the patient who couldn't decide about leaving the mistress or not. However, many times, thank you, Giancarlo, many times
This has been
patients
published in
really,
Spanish if you want.
yes, really,
Excellent.
really struggle because they cannot make decisions, no? And also, we cannot make the decisions for them. So I believe that the awareness process is a gold standard to help them make the decision, no? And that's a question in relation to the behavior. And for the behavior to occur, you need to change, no?
Absolutely.
Mental state. So just that.
Absolutely.
Okay. So I guess we go. Bye, Grace, and hello.
I wanted, Elaine, hello, nice to meet you. I wanted to
Hello.
ask one simple question.
Yes.
Is there a practice law that protects psychotherapists in this medical industry to protect us from, in case of ruptured alliance with patients, where we can run to? Because I had a patient who refused to complete therapy and then late after like 5 months relapsed and took me to court. So I'm waiting for the court, whatever sessions. But what do you do in that case as a medical psychotherapist?
Well, that's a
When
big
you,
issue.
I
I don't
lived in
know.
the UK, so they're like
It also depends on the country you're in, and we are now in Argentina with a huge suing medical psychiatrists and psychologists because of Maradona's death. So
Yeah.
that's a huge issue. I guess maybe we in another time because it depends on the country. No, in Argentina we have a protective law for the
all right.
therapists.
Okay,
We do have.
okay.
Yeah, I don't know, Grace. I'm fully with you, and I think we need more law protecting the practitioners.
Fantastic.
Totally.
We need it more than it's too late.
Absolutely.
We have in Argentina, but Argentina is light.
Exactly.
I agree.
Thank you, Grace.
Yeah, it's nice to meet everybody.
Thank you, Grace, for coming.
Yeah,
See
sure.
you in Krakow.
Bye-bye.
See you in Poland. See you in Poland.
Yeah.
Okay, so
Okay.
thank you all so much for being here. Again, thank you to the presenters for an amazing talk. I do want to just mention that this webinar was recorded and it will be available on our YouTube channel. We will also send the link out to all of the registrants and attendees so you will be able to see it. And I also just want to mention that we have the next Distinguished Researcher webinar on May 30th. And also, we're all going to meet in Poland and in Krakow at the end of June. We're all waiting to see everyone. And I just want to mention that there is an option for virtual attendance. So keep that in mind if you can't attend in person. Yeah, and thank you all very much.
Thank you,
Bye-bye.
Galit and
Thank you.
everyone. Thank you,
Bye-bye.
Clara. Thank
Thank
you,
you.
Thank you,
Clara.
everyone.
Bye,
Bye-bye.
Bye.
Juan.